everyone from Cat Island in the Low Country. Before I get started, I'd like to thank Dr. Walker for the opportunity to participate in this educational series. I'd also like to thank the NCBH team for making it all happen. The title of this talk is The Impact of Venous Disease on Overall Healthcare. Disclosures, none that are relevant to this discussion. So venous disease, we have the chronic form, CVD. We also have the acute form, venous thromboembolism, VTE. And that's comprised of deep vein thrombosis, DVT, and pulmonary embolism, PE. In 2020, if you look at the US prevalence of selected chronic diseases, you see that chronic venous disease at 180 million dwarfs even diabetes at 34 million. All cancers are 17 million. Looking at one component of chronic venous disease, varicose veins, we have approximately 54 million, and 70% of those are female. Symptoms: heaviness, tiredness, tenderness, itching, aching, pain, and swelling, but this may be an asymptomatic condition. Varicose veins are not just a cosmetic problem, but a manifestation of chronic venous insufficiency, that is CYP3 to 6. And varicose veins do progress to more severe disease, including ulcers, at a 2 to 4% annual rate in low-risk patients and at a 5 to 8% annual rate in high-risk patients. We look at current varicose vein treatment patterns, and this is the MarketScan database, real-world database. We see that surveillance with or without compression is 70% of the treatments. Interventional represents 30%, and the single largest category is laser at 10%. An economic case can be made for early intervention in varicose vein patients. Again, this is data from the same MarketScan real-world database. And early treatment was defined as less than 2 months, intermediate between 2 and 6 months, and late treatment between 6 months and 24 months. So early treatment cost $17,600, intermediate costs a little bit more, but late treatment actually cost $18,400, so later treatment costs more. Disease progression also was dependent on treatment category. So in the early treatment group, 29% had their disease progress. However, in the late treatment group, over 50% had disease progression. Venous ulcers, annual incidence of 1 to 2 million. Incidence increases with age, so this is very much a disease of the elderly. Venous ulcer treatment costs for incident venous ulcers between $21 and $46 billion. Now that's considerably higher than the $1.5 to $3 billion you frequently see in the literature. The difference, twofold, somewhat higher incidence numbers, but more importantly, these data are based on current US treatment costs. The other data were based on 1980s treatment costs in Europe. Venous ulcers, you see frequently in the literature also that venous ulcers cost between 1 and 3% of national health expenditures. If you do that calculation, that's 30 to 90 billion. So 20 to 46 billion is considered is in the low end of that range. The annual economic cost of incident disease, venous ulcers, 38 billion, versus diabetes, 21 billion, Alzheimer's, 18 billion, and cancer, 11. VTE, prevalence of between 900,000 and 1.1 million cases, clinical presentation, DVT at 60 to 70%, PE in 17 to 30%, and both in 11 to 15%. 30-day mortality is high at 10 to 30%, and up to a quarter of PE cases present as sudden death. The result, 60 to 100,000 VTE deaths. VTE are preventable. It's been shown that adequate prophylaxis reduces fatal PE by 62% and DVT by 53%. 60% of the cases are hospital and nursing home patients. Over half of hospital patients and 93% of major surgery patients are at risk for VTE. Yet, only 1/3 to 60% of hospital patients receive adequate prophylaxis. VTE costs are primarily inpatient for both commercial and Medicare patients. Approximately 3/4 of the costs are hospital inpatient. The economic cost of incident VTE. There are several ways to look at it. The direct medical costs, all-cause costs, estimated between 17 and 38 billion. The incremental cost of VTE versus matched controls estimated at 7 to 10 billion. And remember that almost 40% to almost 60% of these are preventable costs. Indirect costs of 7 to 13 billion, and these are the costs of premature life lost. VTE are highly recurrent. At 1 year, between 4 and 15% recurrence rates. At 10 years, 1/3 recur. Recurrent VTE costs 2.2 to 3.4 times more. And that reflects increased hospitalizations, length of stay, ER visits, and total costs. And one study found that a recurrent VTE costs $12,000 more than a primary. Complications also increase the cost. Post-thrombotic syndrome occurs in 30 to 50% of DVT patients. Heparin-induced thrombocytopenia occurs in 0.5% to 5%. Chronic thromboembolic pulmonary hypertension in 1 to 5%, and bleeding, both major and minor, around a 1% rate. Now, each of those complications adds to the cost. So PTE can add $1,000 to almost $8,000 to total cost. HIT can add between $5,000 and $7,000, and a major bleed can add between $10,000 and $23,000 to total cost. So conclusions. At 180 million, venous disease is the most common chronic disease. Varicose veins are ignored. Even if the patient's legs are examined, they are dismissed as just a cosmetic problem. However, varicose veins are a serious disease progressing to more severe venous disease, including ulcers, at a 2 to 8% annual rate. And 2 million venous ulcers cost $21 to $46 billion annually. VTE is highly prevalent and costly, between 17 and 38 billion. The majority of VTE occurs in the hospital and the nursing home, but is not adequately prevented. Recurrent VTE and complications add significantly to morbidity, mortality, and costs. And chronic venous disease is underestimated, underdiagnosed, and undertreated. So thank you.